Good afternoon, everyone, and welcome to Cord Connects. My name is Moshe Weitzberg. I'm a member of the Cord Board of Directors. I am joined by my partner, Dr. Marianne Howie, who is also a member of the Cord Board of Directors. I would like to welcome you to Cord Connects. Our session today is on innovations in new resident orientation. Our speakers today, I will introduce now. Our first speaker is Dr. Arlene Chung. Dr. Chung is the Emergency Medicine Residency Program Director at Maimonides Medical Center in Brooklyn, New York. She is the past chair of the Cord Resilience Committee and continues to be active in initiatives focused on resident and faculty well-being. Dr. Shivani Modi is an Assistant Program Director and Assistant Medical Education Fellowship Director for the Maimonides Medical Center Emergency Medicine Residency Program in Brooklyn, New York. She is an active member of FemInM, and her interests include gender equity and membership. I turn the floor over to our speakers, Dr. Chung and Dr. Modi.
Thanks so much for having us here. It's really exciting to be able to talk about resident orientation. I mean, July is right around the corner, and I'm sure anybody who's listening on this call right now is thinking ahead to see how can we best introduce our newest trainees into the culture of emergency medicine and set them up for success. In thinking about orientation, how can I advance my slides? Here we go. In thinking about orientation, Dr. Modi and I were thinking about how to best break this down into sort of a manageable framework. And one of the things that we discussed was when you think about learning and you think about training emergency medicine residents, you can kind of break down their education into 4 different categories. That would be knowledge acquisition, skills, attitudes and values, and then the behaviors that they exhibit. And we felt that, given this framework, which is pretty common in medical education to begin with, would be a really great way to sort of frame intern orientation, whether you're implementing innovations or actually just using a lot of standard stuff that is pretty common across the board. I mean, I think most of us recognize that people who are going into emergency medicine sort of expect July to be a transition month for them from when they come as medical students and then before they start in August in their clinical shifts, as kind of a time for everybody to get on the same page and to sort of normalize equalize the experiences that people may have had in medical school up until then. Now, looking at the KSAB, or knowledge, skills, attitudes, and behaviors, the question next is, okay, fine, so we have this framework and how we want to address orientation, but then how does that translate functionally into what I'm actually going to do with these new trainees when they come in? And so in thinking about this, Dr. Modi and I felt that the way to think about this might be, so if you want to teach your new residents knowledge, that's functionally classroom teaching, formal didactics, the formal curriculum. Skills is fairly straightforward. That tends to be procedure workshops, getting them up to speed on how to splint, how to suture, some basic airway management, and vascular access. Attitudes and behaviors are a little more nebulous in thinking about it, but when you're trying to translate these ideas into sort of practical, hands-on stuff to do with your residents, one way to think about attitudes and values and how you create that is to think about the culture in your residency program. Each of us is pretty familiar with our own culture, and each of our cultures are a little bit different. There's obviously the broader culture of emergency medicine and what it means to be an emergency physician, but within those, each of our residency programs has its own little microculture. And it would probably be worthwhile to spend some time thinking about what is exactly the culture of your program and how do you want to indoctrinate your new trainees into that culture so that they feel welcome and then they feel like part of the family when they come in. And finally, behaviors. How do people act? How do people behave? One way to look at that in sort of a way that maybe is more understandable to us in residency leadership is to think about professionalism. What does it mean to act like a doctor, to behave like a doctor, to present yourself to the world as a doctor? For many of these trainees, this may be their first job, right? They may have been students all the way up until this time, and this is really their first chance to be professionals out in the world. And so how do you translate what you know to be appropriate behavior and make sure that you set them up for success going forward, that they can do that themselves and succeed in residency and even beyond then. So in looking at this framework, knowledge, skills, attitudes, behaviors, we're actually going to break down the following bit of our lecture into these 4 different categories as well. And you can feel free to take bits and pieces from this. I hope some of this is useful. Some of it may be new. Some of it may be familiar to you, but I hope everyone comes out of this with some great ideas. So even before they come, and actually this is sort of a little bit outside of the KSAB that I had mentioned earlier, even before your new trainees show up, there is stuff that you can certainly do. And we call this sort of like the pre-orientation, or the orientation before the orientation, or I guess the orientation to the orientation could be a way to look at it. But essentially, as soon as they match in March, you have some time between March and July that you can actually use to set them up and get them prepared for when they come to actually join their shop. One of the things that I've seen both at the programs that I've been at and the programs that I've had conversations with my colleagues is it's pretty common to send a welcome packet of some sort, some kind of welcome message to your incoming class. And this can be as early as match day. It can be a brief letter from the program director. But what is helpful in following up that brief letter would actually be some tangible, like nitty-gritty information that they're going to need to help get oriented to potentially a new city, a big cross-country move. And so stuff to include in a welcome packet might include things like how to find an apartment. So Dr. Modi and I both practice in New York City. And for those of you who have never been to New York, finding an apartment in New York can be its own challenge. And so we certainly include that in our welcome packet. Other things might be, how do you find a local doctor? Are there doctors that are recommended? Setting them up for regular primary care visits. How do you find a dentist? How do you find a sitter, whether it's a dog sitter or a babysitter? Where do you get your laundry done? Who's the plumber? What are the different neighborhoods? Where do you eat? Where do you grocery shop? Where do you do your laundry? All of these other things, because it can be pretty daunting and it can be very helpful for people who are going to make this big cross-country move potentially, or even if it's just down the street, to have some of this information available. You can also use it as a time to orient them to some of your current residents. And so with the welcome packet, you could also potentially send photos of the current residents, some fun facts about each of them, and sort of get them to feel like they're going to become part of this amazing family that they've now matched into. One thing that can be helpful before they show up in July is actually to have an informal meet and greet. Remember, these interns, they don't know who each other are. And when they show up for that very first day of GME orientation, I can imagine if I was a brand new intern coming in, meeting some other brand new intern and being like, oh, you're an EM intern too? And so to sort of make sure that they all know each other ahead of time, it can be useful before the GME orientation to actually have an informal meet and greet. And oftentimes, like, the chief residents can organize this, or the residents can organize it for themselves, but just so they actually know who each other are, and so they can go through those weeks of GME orientation, having that support in place. And finally, this is the era of technology and foam. Certainly, there's a bunch of tools available to help get these guys a leg up, and you can certainly get them started on some asynchronous learning, whether it's through Slack or whether it's through Google Docs. I mean, those are sort of two common pathways. Our interns are actually currently engaged, or our incoming class is currently engaged in a pre-orientation curriculum via Slack. So essentially, they've all logged into this platform, which, if for those of you who are unfamiliar with Slack, if you remember back in the days of the AOL chat room, just picture this. And it's essentially an asynchronous learning environment where one of our residents and one of our faculty members, they will post a case, and it can be something like a 50-year-old man presents with substernal crushing chest pain radiating to the left arm. Here is his EKG. And there's a series of clinical questions that follow that. And the interns are expected to sort of chime in as they get around to it. So what they think the differential is, lab tests they would order, any relevant differentials to consider. And the faculty, and we have one faculty member and one resident who are running these cases, and then they chime in and they precept and they help guide the discussion. And so we have a series of 10 cases that our incoming interns are doing in order to get them sort of in the groove of emergency medicine, get a little bit of a taste for it, and also to help relieve some of the burden as far as formal teaching that we would need to do during intern orientation itself, which is a nice segue to the next bit. So knowledge. How do you teach residents knowledge when they first come in July? In some ways, this is probably the most straightforward means of education that we're used to. This is a photo of our residents who attended a large New York City conference. So one of the things you can do, obviously, is if you have a local conference that occurs in July, one nice thing that you could do is actually send your class, send your new interns to that conference. And they'll get to meet some residents from other areas and hopefully learn some stuff too. Knowledge is sort of like the formal curriculum, formal teaching. So there's obviously traditional didactics. You can have set up a series of lectures, whether it's chest pain, shortness of breath, CHF, stroke, altered mental status, and enlist some faculty members or even senior residents who are interested in education to give those didactics. Perhaps a more interesting way of getting your learners engaged, though, might be to do a little bit of a flipped classroom. So this would involve assigning some homework and some readings and some questions ahead of time. And really, instead of doing a traditional classroom lecture, to do more small groups and problem-based learning and case-based discussion. Generally, your learner group is going to be smaller since it's just one class of residents. So this might actually be an ideal time to try to pilot a flipped classroom, particularly if you're actually not doing it in your regular sort of, whether it's a Wednesday conference or Thursday conference. This might actually be a good time to try to pilot it if you've been flipped classroom curious but haven't actually tried it out yourself. There's plenty of resources online on flipped classroom, and I know Cord has published a bunch on it, and so you're welcome to go check those out. But I find that as far as delivering traditional core content, flipped classrooms and small groups can actually be a great way to do it. When you're thinking about your topics, one thing that I find in speaking to residents has been that rather than, let's say, having your topics be ACS, COPD, CHF, biliary colic per se, so rather than having them diagnosis-based or sort of illness-based, instead to have them as a signs and symptoms approach. So in this case, it would be like the approach to emergency medicine. So the approach to chest pain, the approach to the patient with altered mental status, the approach to abdominal pain, and actually introduce them to some common flow charts and sort of like, you approach a patient with abdominal pain, what are the relevant parts of the history that you need to obtain? What are relevant physical exam maneuvers? What are your common lab tests that you'll do? What's the differential? And framing your traditional classroom didactics in the approach to, rather than being, say, on a specific topic like COPD or cellulitis, for example. In this approach to model with flow, you can create flowcharts or infographics if you're into that type of thing, but you can also incorporate things that are specific to your emergency department, which is really nice. So every ED has its own little quirks as far as, how do you order labs? How do you get the lactates to be correct? How do you get the patients to x-ray? Where is x-ray? Are there any special procedures or people that you need to call in order to make those things happen? This is a really great way to integrate the pure medical knowledge into a more practical knowledge that the interns can use when they actually go out into the, into the world, into the clinical environment. Hopefully give them a little bit of a leg up and really make them feel like this is not just esoteric that they're learning, but that this is real practical stuff that they're going to need to know in the next few weeks. Finally, a last way to deliver knowledge is sort of fun stuff, games. You can certainly implement things like Jeopardy, card games. You can do scavenger hunts are pretty popular. So in this case, you would give a list of items that they need to find in the emergency department. So where are the medication carts? Where is the charge nurse's desk? Where is the ultrasound located? Where's the peds department? Where's the cafeteria? Where's the cath lab? And sort of have them go off in teams or individually or all as a group to find those different places in the hospital. This might also be a really good way to introduce them to the staff in the ED. This is not strictly knowledge and perhaps falls under one of the different categories, but certainly a scavenger hunt into learning the nurses' names, learning the techs' names, learning who your patient reps are, where people sit, and who the attendings are. You can certainly incorporate that into a more either a scavenger hunt or a game type approach. So in some ways, this is probably what we're the most familiar with, but I hope at least a few of these things might get your creative juices flowing as far as how you can deliver traditional medical knowledge in a slightly more innovative and interesting way to your new learners.
All right, so next we're going to cover skills, which really translates to our residents' procedural skills. And with our interns, we really want them to go into their shifts at least having a basic idea of how to do procedures that we encounter in the ED all the time. And of course, we're going to rerun how to do these procedures with them in the emergency department, but it's nice if they have some common knowledge coming in, so you're not spending a lot of time on shift going through the basics with them. So there's this is a picture of our current interns who during their orientation, going over how to do a chest tube, how to do a central line, basic things. And so there's many ways in which to do this depending on which resources you might have available at your institution. So do you have a cadaver lab or a pig lab that's available to you? Do you have a sim lab? You can do models. So there's a lot of options online that you can look up that are reasonably priced and high yield models that you can use for your residents. And then virtual reality is also becoming a big way to help our residents learn how to do these procedures. And you can actually do a combination. So whatever you might have available to you, you can make it happen in any of those ways. So the idea during these sessions is to teach the residents a step-by-step approach and provide them with resources that they can reference while on shift. So give them links to videos, or, don't forget to do your timeouts. Give them resources that they can use, that they are able to pull up quickly. And then think about the procedures that you want to run through. So here we tend to run through basic things: central lines, basic airways, chest tubes. And then the other thing that we might do is splinting and suturing, as well as learning how to use basic equipment in the emergency department. So slit lamps, tono pens, and these are things that they're going to encounter every day. Best thing we can do is engage our colleagues. So using what you might have available to you, whether that's orthopedic residences or optho, plastic surgery, engage those colleagues, whether they might be residents or attendings, and have them come teach your interns. This is not only a great way to make sure that your interns learn how to do these procedures in a way that's acceptable to your colleagues, but it's a good way for them to get to know the people in the hospital. And so next time they're calling the ophthalmologist for an eye injury, they're gonna know this ophthalmologist wants me to give them the presentation in this way. They wanna know visual acuity, they wanna know eye pressure, they wanna know what the ultrasound shows. And that way, not only is your resident better at giving these consults, but the consultant is much happier with what they are presented with, and are happier coming in if they need to come into the emergency department. The next thing we do is have our residents go through an ultrasound day. Many of the medical students have now started doing ultrasound rotations and are actually pretty well versed in doing ultrasound. But this is a great way for them to get to know our ultrasound faculty, how to use the ultrasound machines that we actually have in our department, how do you save your images so they can be appropriately billed to your patients, and then going over the basics. So for those who actually haven't had any ultrasound training, how do you do a basic echo? How do you place a peripheral ultrasound guided IV? How do you do your central line with an ultrasound? And we find that the residents really are able to use this starting day one. We have our residents go through shadow shifts. So we find time, we do our first, like Dr. Chung mentioned, we do a month of orientation, and we find time for our residents to come in on shift and not only just get to know their co-residents, get to know the attendings, get to know the nursing staff, the PCTs, how the ED functions, how to log into the computer system. And they might only see 1 or 2 patients on that shift, but it's a really good way for them to get to know the department while they're not a part of the crucial staff that needs to be there that day. It's a time for them to ask questions. It's a time for them to just become more familiar. And lastly, nursing shifts. So nurses are a big part of what we do in the emergency department every day. And we know that they do much more than we can ever imagine. And so having our residents spend some time with them. How do the nurses function? What goes on during their shift? How many orders are they doing within a shift? How many meds are they being asked to order? And in doing this, they not only see how the flow works for the nurses, but they learn how to place peripheral IVs. They know that, okay, if I'm ordering this blood work, which tubes do I need to send? How do I place the leads to do an EKG? How do I set up a monitor? It's basic skills that they can learn how to do and actually help out with in case their nurses are really busy, or the next time they're asking a nurse, they're actually going to know who that is and have a better relationship, so things actually get done in a faster manner for the patient.
Which brings us to the end of the easy part. So again, as I mentioned earlier, the formal curriculum in medical education is often something that's a little bit easier and more tangible for us to grasp, and that's generally classroom knowledge, medical knowledge, procedural skills. But the second half of this talk is a little bit more nuanced, a little bit more complex. How do you introduce your new trainees into the culture of emergency medicine in a way that is healthy and will set them up for a career of success going forward and ensure their career longevity and lifelong learning? Which brings us to the second half of this talk. You know, I know pretty much everyone listening here is going to be familiar with this bit from the Common Program Requirements, but the ACGME has really taken a focus on resident well-being, and there is no time like the present, or I suppose no time like July, if you want to look at it that way, to really introduce trainees in a healthy way to emergency medicine. For better or for worse, I guess every specialty has a particular stereotype. I think we all know what emergency medicine stereotype is, and I feel like medical students who are graduating probably have this concept of the way emergency medicine they think it is, which is a group of people who work hard, play hard, see a million patients, do a bunch of procedures, and then go base jumping in our free time, which all of us listening here know is probably not true. And so the question is, how do you introduce them to have a healthy attitude and healthy values towards the practice of emergency medicine, and really become a well-rounded physician? As we all know, in some ways, the easy part of being a doctor is the stuff that you learn in textbooks. The hard part of learning how to be a doctor is how do you orient as a human being, and how do you really empathize with your patients and communicate with your patients and deliver holistic care in a way that is not just fulfilling for the patients, but also fulfilling for the physician as well. We just had our resident retreat. Actually, speaking of well-being, Dr. Modi and I got back earlier this morning, but this is a photo hot off the press as we did one of our small groups talking about a subject sort of similar to this at a very beautiful place in the Hudson Valley. So how do you deliver, how do you teach the hidden curriculum? I guess this is another way of looking at it. If the first two sections of this talk were focused on the formal curriculum, the second half of this talk is really going to be focused on the hidden curriculum, which is essentially culture. How do you introduce these new trainees to the culture of your program? There's a number of ways to do it. A fairly straightforward way would be to do something like a journal club or book club, but rather than doing a straight clinical topic, to pick a piece of writing that perhaps emphasizes the patient experience or cultural competency or empathy or breaking bad news or coping with a patient death, something that really lends a little bit of itself more towards the medical humanities and really opening up to the spectrum of feelings and emotions that they may experience out in the clinical environment, and having a discussion related to that. Certainly you can throw a welcome party. Again, a lot of orientation is just about simply meeting people and actually, in many practical ways, becoming part of the family. People you may want to consider would be not just the residents, but of course to introduce the faculty as well, because the faculty are going to be such an integral part of their education. Most departments will also hire new faculty, new fellows every July as well. And so this is a really great way for all of those people, not just the new trainees, but also the new faculty members in your department, to become oriented to the culture of the program and get to know everybody in a slightly more relaxed and informal setting. The next item is something that I think is super innovative, and as much as I would love to take credit for this idea, I'm not going to be able to. This idea actually came out of an idea from one of my friends out at LA County, USC in California. But one of the things that they started doing was to really enlist the help of a support network for each of the residents. So every resident out there has some person, whether it is a family member, whether it's a parent or a spouse or a best friend or a roommate, that they know who they're close with. And this may not necessarily be a medical person, but identifying who that person is. So you basically ask each of your new trainees, please identify one person who's close to you, and write down their contact information. And so one of the things that we've started doing with our trainees is to ask them that very question, because really, I think in some ways, those are the people who, if you can enlist them as allies, can really help to enhance your new trainees' experience as they go through some of the hardest years in their lives. What we've done is we've obtained we obtain the contact information of whoever the residents identify as their support network person, and we call them. So they receive a call from one of our residency leadership saying, "Hi, my name's Dr. Chung. I'm the program director. I just wanted to introduce myself to you because your husband, wife, brother, sister, roommate is now starting residency, and they've identified you as a really important person in their life. And I wanted to just let you know that I'm always available if you have any questions about their training or what they may be going through, or how, if you have questions about how you can best support them, I'm always here available. Here's my contact information." And so that we can start developing those networks between them. Certainly, if you have the welcome party, by all means, invite that person that they've identified as their support network to the party. So, that person can also feel integrated. Obviously, it's a way to sort of reinforce those connections and that support network during residency, but also, truth be told, worst case scenario, if anything terrible or tragic were to happen to that resident, it would be much better for everybody involved if you already had a relationship with that person who's very close to them and you had their number and you've already established yourself as who you are in that program. I think there's so many benefits to identifying who this support network person is for each resident, and really making efforts to strengthen those ties. And finally, as far as culture goes and the hidden curriculum, and sort of developing the appropriate cultural attitudes to emergency medicine, some of the best ways to do it are simply to talk to one another, to find spaces during orientation in smaller groups, either among the new trainees themselves, so you can have them share their fears, their hopes, their dreams about residency going forward. This is a great space to do something like a letter to your future self. So I've seen this done at a couple of different programs where there'll be a session where the new trainees can sit down, they get 30 minutes and they can write a letter to themselves that then they'll open in 6 months or a year or even at graduation, just as far as things that they hope to accomplish, the doctor that they hope to be. And really it's a self-reflective exercise. And you can even have a discussion afterwards once everybody's done with their letters. Having faculty come in and share some of their experiences as residents can be really powerful. Having some of the current residents come in and share their experiences as interns can be very powerful. Our intern class, bless their hearts, they are doing something called the Intern Project, where among themselves, they've actually collected stories and written them down, and actually they're going to collect them, put them in a little booklet and present them as a gift to the incoming interns, which I think is a fabulous idea. And lastly, along with all of this discussion and this sharing and this vulnerability and this normalization, one thing might be a good topic to cover would be something called a growth mindset. So there's a concept of fixed mindsets and growth mindsets. And fixed mindsets is this idea that you are born with a certain level of intellect and a certain level of ability, and that's it, right? You either got it or you don't. Whereas a growth mindset allows for the flexibility of somebody to grow and improve and learn from their mistakes, and really become, and really work on themselves to get from point A to point B. Unfortunately, I think a lot of medical education really focuses on a fixed mindset. There's a lot of, you have to get this score, you have to get this grade, you have to get into this place, that doesn't allow much room for failure. But the truth is, and so many of these trainees may have come in never having experienced failure in their lives, because this is the cream of the crop that we're talking about that have made it through college, through medical school, and have matched into your training program. This may be the very first time in their life that they've really experienced failure, that they've really encountered something that they were unable to do. And so setting this up at the outset, that failure is okay as long as you learn from it, can be really powerful for them, because there are going to be hard times ahead and they're not going to know how to do things, and they are going to have bad outcomes. And to prepare them for using those as learning opportunities rather than an opportunity to sort of beat themselves up about it can be a very great way to set them up for learning for the next 3 or 4 years.
All right, so next we're going to talk about behaviors. And as Dr. Chung mentioned, this is one of the hardest things to teach and get across, and probably a little bit of part of the unwritten curriculum with intern orientation. And so for many of our interns, this may be their very first job. And they're finding themselves and they're still figuring out what to do next, and when they're not being told exactly what to do by their teachers or by their parents. And so it's our job to guide them through this. And also they're going through the idea of personal identity formation. So they're trying to find themselves as doctors. How do they act like a doctor? How do they behave like a doctor? How can they be perceived as a doctor? So it's our job to help them get to this point. And so, for example, our residents may think that, this is a group of our interns this year, and we had them all get their white coats and their brand new scrubs, and had them take some professional photos, which was part of this idea of personal identity formation. And so something to realize is that there's a lot of preconceived notions of what people think emergency medicine doctors are. And so the idea may be that we're cowboys in the field, we do all these crazy procedures, and it might lead to our residents wanting to do things in the ER that we might not be so comfortable with, or it might lead to this wellness bias of wanting to send our patients home. And so it's our job to help them realize that although there are these kind of preconceived notions of what EM doctors are, each resident has to find themselves. And so our generation of interns is a generation of millennials. They may never have had to go to class. They may never have had to do homework. They just show up to take their tests. And so suddenly they come to residency and they are required to do asynchronous learning. They're required to come to conference. There might even be required to give presentations. And so it's our job to help guide them through this and realize it's very important for them to show up to these things, to show up on time, and to be respectful of everybody who's putting in their time and energy in helping to educate them. And so other things to remind them of, answering their emails, finishing their charts. In the past, they've never had to do these things. And so reminding them that this is their career and their future career, and they need to be timely with this. And then things like how to dress, making sure you look professional, making sure you're presentable to your patients. How do you act in and out of the hospital? So with social media being so prevalent, it's really easy for our residents to post pictures of themselves drinking or partying or out doing the craziest things they did over the weekend. And it's a reminder that these things are pretty much saved forever on the internet and can be accessible by not only their bosses, by the chairs of our departments, but also their patients. And so again, reminding them that everything they do is a reflection of who they are as a person and also as a physician. Reminding our residents that they're program coordinators. That's a really important person in their lives. That's who's going to be helping them get their paperwork done, who's going to be making sure that they have things ready to go when they're looking for jobs, who's going to be setting up some of their rotations. So reminding them that this person is not just their program coordinator, but someone who's really going to make their life easier and make it so they can actually get through residency. And then finally, something that we do to kind of bring this all together and as a good reminder for our residents is a professionalism contract. So a document that lists all of these things, and although they sound simple and we don't want to treat any of our residents like children because they're all adults, we want to make sure that we set them up for success. So again, showing up on time, answering your emails, finishing your charts, being cognizant of how you act in and out of the hospital. And then lastly, how to get feedback, how to continue growing as a resident, as a physician, as a person, and being humble about it. So how do you work with your attendings? How do you work with your co-residents? How do you ask for this feedback? How do you take constructive feedback when you don't necessarily agree with it? And so these are all things that we try to talk about in terms of professional behavior to help set our residents up for the best success.
I just wanted to say a few wrap-up words and closing comments. I mean, so you go through this July, maybe you take some of the ideas that we've presented here, maybe not, maybe you do what you're currently doing. At the end of it, it can be really helpful to get some comments, get some feedback, right? We're all educators here, so we're all obsessed with feedback. But certainly this is something that's really tangible. And it doesn't have to be feedback that you get from right at the end of intern orientation. So certainly, you can always, it's probably easier to capture them right at the end of orientation. And so you can send out a Google form or a paper form and say, did you like it? Would you recommend it to a colleague? We've all created forms like this. But what can be really helpful is actually assessing them right at the end of orientation, but then assessing them, say, 6 months later and see what did they actually remember from orientation, because it may be surprising that the things that really stuck with them during orientation may not actually be the things that you remember teaching them, or they may be unexpected. And so you can take that feedback and use it for the following year. So doing a delayed assessment once they've gotten their feet wet in the real clinical environment can be really helpful in tailoring your orientation for the following year. Something also to consider in that same line is having, I guess you could call it an orientation part 2 or an orientation redux at some point midway through the year, a few months into the year, where you may not be able to capture all of the interns, but certainly you could get a good proportion of them. And now that they have a few months of clinical experience under their belt, maybe try to reorient them to the topics that they may have understood while they were in July before they started, but now that they've had some real clinical experience, they really understand on a more visceral level, and try to revisit some of those topics. Ideas would include, again, in those second half, the second half of our presentation, revisiting items like cultural competency, the patient experience, normalization of feelings, fears, hopes, dreams. Those types of things may be really useful to revisit after a few months in the ED. And lastly, to remember, get some help. You do not need to do this by yourself. Regardless of how big your residency leadership team is, whether you have 1 APD or 6 APDs, or you're doing it on your own because you're revamping your whole residency leadership, you do not need to do this by yourself. Generally, residents of all the different educational opportunities for teaching, orientation is almost universally one of the most popular ones because they all remember what it was like to be a brand new trainee. They all remember what it was like to be a student and to suddenly be put in the shoes of a doctor and to have to orient to that environment. Most of the residents are pretty open to pitching in, whether it's taking them on a tour around the ED, whether it's teaching a didactic, whether it's leading a small group session or a procedural workshop session. You do not need to do this alone. You can certainly enlist help. You can enlist help from colleagues that are nearby. As I mentioned early on, sometimes there are regional conferences that happen to be going on in July. And if you have the resources, it may not be such a bad idea to ship off your new class and have a different place teach them for a few hours. It might be a good way for them to experience something a little bit different than their home institution, meet some new people, and it gives you a bit of a breather too as far as trying to plan your orientation month. And then finally, just to wrap up, so we've covered, basically our approach to, I'm going to recap sort of our talks, we covered an approach to orientation and looking at a framework of knowledge, skills, attitudes, and behaviors. And I think that by using that framework, you'll pretty much cover everything. The knowledge component is essentially the formal curriculum and straight up medical knowledge, which can be delivered in a variety of ways, whether it's classroom sessions, small group learning, asynchronous curriculum. And some of that asynchronism can actually be delivered before they even show up in July. The skills are fairly straightforward as well. A lot of it is procedure labs, a lot of it's hands-on training. Some of it's actually getting to know some people in the ED, so working with nurses and getting used to doing procedures in the clinical environment. Attitudes and behaviors are a little bit more complex, a little bit more challenging, but certainly not insurmountable. Things like book clubs, things like frank and open discussions with faculty members, with other residents, finding safe spaces for them to share their fears, their hopes, their dreams, introducing them to what it means to be a doctor, what appropriate role modeling looks like, who they should aspire to, some of the professionalism duties that they may never have had to experience as learners because this is their very first job that they've ever had. Certainly doing those, introducing them to all those things, whether it's a small group session in a classroom or a small group session off campus outside in a beautiful location with other residents. Certainly each of them can be used in their own right depending on your location and your resources. And I hope with that, all of you out there have maybe some of this is familiar, hopefully a little bit of it is new. Our main hope and our goal is that this has inspired you to go forward, to maybe rethink what you got going on July, if not for this year, but hopefully for the years going forward. And with that, we're happy to answer any questions. I see that there may be something in the chat box, but I am unable to read it. So actually, Tina or Moshe or Marianne, if you want to field any questions, we'll be happy to answer them.
Sure. So first of all, thank you very much to Dr. Chung and Dr. Modi for a wonderful presentation. I certainly picked up some pointers that I would like to bring back to our intern orientation. We would like to open up the floor to questions now, and for Dr. Modi. So you mentioned in terms of procedure preparation that you utilize virtual reality to help teach procedures. And I was wondering if you can give us a little bit more information about what that's like and how you make that happen.
So with virtual reality, there's a lot of different ways in which you can use it. For us specifically, we're able to use it to help our residents with interactions. How do you do your physical exam? And rather than using it necessarily for procedures, we use it in that way. But there are ways to use virtual reality in which you are able to identify maybe in respiratory distress and which modalities do you want to use for their airway and have residents practice that way. So more for the patient experience rather than using it specifically to practice procedural skills.
Yeah, one day, I have this vision of like medical education in the future where eventually Stim labs are going to go away, and people are just going to put on like full body suits and have like tactile, sensors in their hands, and that's how they're going to learn. But until that day comes, we still have the goggles.
Yeah, it's funny you mentioned that. We've been looking into that in our program as well. There have been some presentations at Cord AA on that topic, and I was just excited to hear what people were doing. Dr. Howie, I see you posted a question. Would you like me to read it for you, or do you want to go ahead and ask it yourself?
Do it. There we go. I think I've accomplished it. I love the idea of this a mid-year orientation, like a reorientation in the middle of internship year. I'm trying to figure out how I can figure out the scheduling, because it feels like one of the real benefits of orientation is that it is so inclusive and everybody's in the same room. But I really don't have that luxury the rest of the year. So I'm not sure how I would think about going about that.
I know. It can be challenging with the residents dispersed everywhere, particularly intern year when they tend to be doing a lot of off-service rotations. Obviously enlisting the help of your chiefs or whoever does the scheduling for the ED can be important, but if you really can't get them off of off-service rotations, and there are many of them that are dispersed in that mid-year time zone, one way to do it is actually to just leverage technology. So certainly our interns spontaneously, I guess they're more techy than we are, started using Slack as a platform. But using Slack or using some other, messaging app or social media app to connect people, if not like in the same space at the same time, at least reconnect them in that way can be one way to do it. Also, certainly getting people together in 2 different groups would be a way to do it. Trying to schedule a dinner rather than a full day. There's sort of some other ways, but I agree that July is like ideal because everybody is off and everybody's free then. But unfortunately in July, people just don't have that like real patient care experience under their belt. So some of the stuff that we talk about in July, I don't think they really get it until they're released into the clinic.
Okay, well, I would really like to thank our speakers today, Dr. Arlene Chung and Dr. Shivani Modi. Thank you all for joining us. Our next Cord Connects session will be June 27th. The topic will be how to do bedside teaching. We are looking forward to seeing all of you there. Have a great day.
Thank you so much for having us.
Thank you.
Thank you, everyone.
Thanks, everybody. Thanks, Arlene, too. Thanks, Moshe.